We're hitting normal and stress metabolism, malnutrition and clinical assessment, estimating energy needs, oral diets and enteral support, and finally, parenteral nutrition and its complications.
Starting right off with Section 1, normal and stress metabolism. Because before you even think about feeding a patient, you've got to understand their exact physiological state.
Okay, let's talk baseline energy yields. You really need to pay attention to the distinction in carbohydrate yields here. Enteral carbohydrates give you 4 kilocalories per gram, right? But parenteral formulations are hydrated, so they actually only yield 3.4. Keep that in mind. Lipids will give you 9, and protein provides 4. And you definitely want to lock this next fact away. A strict minimum intake of 400 kilocalories of carbohydrates per day is required just to minimize protein breakdown. Now, the absolutely crucial point here is the contrast between simple starvation and physiologic stress. They are totally different beasts. In simple starvation, glycogen is completely gone in 24 hours. And by day 10, the brain adapts to use keto acids, which is essentially a protein-sparing effect. But physiologic stress, like from surgery or a major trauma, that is a highly catabolic state. It's aggressively driven by elevated glucagon, glucocorticoids, and catecholamines, alongside reduced insulin. And all of that leads to massive urinary nitrogen excretion and super rapid protein depletion.
So, how does physiologic stress resolve? Well, it happens in 3 chronological phases. First up is the catabolic phase, which is marked by that high metabolic demand and protein loss we just talked about. Second is the early anabolic or corticoid withdrawal phase. This is where the body finally shifts into a positive nitrogen balance and you see a rapid gain in weight and muscle. Finally, we hit the late anabolic phase, where that nitrogen balance equilibrates and adipose stores are just slowly, gradually replenished.
Moving on to Section 2, malnutrition and clinical assessment. Let's look at how we actually spot a compromised patient on the surgical ward. You absolutely must be able to differentiate these two states, and the key is chronicity. Marasmus is a chronic deficiency of both protein and calories. These patients lose weight, they lose skeletal muscle, but, and this is a big but, their visceral protein stores remain totally normal. Kwashiorkor, on the other hand, is an acute, severe catabolic protein loss. This is triggered by massive stress. Think a major burn or trauma. It rapidly depletes those visceral proteins, which results in hypoalbuminemia and that classic generalized edema. Let's do a rapid-fire review of the most heavily tested vitamin deficiencies. Vitamin C is essential for collagen synthesis, so a lack of it causes scurvy and will severely impair wound healing. B1, thiamine, prevents beriberi and heart failure. B5, which is niacin, is famous for the pellagra triad, dermatitis, diarrhea, and dementia. And of course, vitamin K is absolutely critical for synthesizing your clotting factors. Don't forget that one. We also have to keep track of trace elements. The absolutely essential one to lock down for surgery is zinc. A deficiency there leads directly to impaired wound healing, alopecia, and a poor sense of taste or smell. Also keep an eye on chromium for glucose intolerance, copper for hypochromic microcytic anemia, and iodine for thyroid dysfunction.
All right, Section 3, estimating energy needs. When we're calculating the fuel, precision is everything.
We actually monitor what the patient is burning in real time using the respiratory quotient, or RQ. An RQ of 1.0 means pure glucose oxidation, 0.8 means protein, and 0.7 means fat. And here is a massive clinical pearl for you. If you overfeed a patient carbohydrates, their RQ pushes up toward 1.0, which generates excess CO2. Why does that matter? Because this high CO2 load can make it incredibly difficult to wean them off a ventilator. It's a hugely important concept.
Now, protein requirements escalate dramatically with stress. Think about it. A normal, non-stressed patient only needs about 0.8 to 1.2 grams per kilogram per day. A critically ill patient requires more, around 1.2 to 1.5. But if your patient is facing massive catabolic stress, like severe burns, sepsis, or if they're obese, that requirement spikes all the way up to 1.5 to 2.0 grams per kilogram. Moving to Section 4, oral diets and enteral support. The golden rule of surgical nutrition, and you've probably heard this a million times, is if the gut works, use it.
But when does the gut actually wake up and work after an open abdominal surgery? It actually happens in a very specific sequence. The small intestine is super resilient. It returns to function within hours. The stomach takes a bit longer, usually about 48 hours. And the colon is the slowest of the bunch, typically waking up around 72 hours, which is clinically marked by the passage of flatus.
Thankfully, we don't just sit around waiting for the gut to wake up anymore. We use ERAS, or Enhanced Recovery After Surgery. This is an awesome multimodal pathway designed specifically to hasten GI recovery. We do early enteral feeding, we use epidurals to avoid those motility-killing narcotics, and we give peripherally acting mu-opioid antagonists like alvimopan. The result? You can literally reduce postoperative complications by up to 50%, a real game changer. When you're deciding on a nutritional approach, the algorithm is straightforward. Always start by assessing GI function. If it's normal, you prioritize standard enteral feeds. It is only when there is an absolute contraindication to enteral feeding, things like an obstruction, severe ischemia, or a high-output fistula, that we divert our path and start anticipating parenteral needs. So why do we push enteral feeding so hard? It's simple. It maintains the gut's cytoarchitecture and mucosal integrity, which prevents bacterial translocation. But you've got to follow the rules. To prevent fatal tracheobronchial aspiration, you must always elevate the patient's head 30 to 45 degrees, and you have to strictly monitor gastric residuals. If that residual volume is greater than 50% of the previous bolus, you hold the next feed. No exceptions. Now, when you're initiating feeds in a severely malnourished patient, you have to be incredibly vigilant for refeeding syndrome. This is a highly tested and, more importantly, potentially lethal complication. As anabolism suddenly restarts, the cells pull electrolytes out of the serum, and this leads to dangerous systemic drops in phosphate, potassium, magnesium, and thiamine. It can trigger sudden, deadly cardiac and respiratory failures. Which brings us to Section 5, parenteral nutrition and complications. This is our absolute last resort when the alimentary tract is just completely unavailable. You have two intravenous options here. First is PPN, or peripheral parenteral nutrition, but it is heavily restricted. Because it's going into peripheral veins, it's strictly limited to 900 milliosmoles, which means a maximum of 12% dextrose, just to avoid severe phlebitis. And to get enough calories that way, you'd need massive fluid volumes, over 2,500 milliliters. Total parenteral nutrition, or TPN, solves this, but it requires a central venous catheter. It allows for a complete, highly concentrated 3-in-1 admixture of your protein, dextrose, and lipids. One huge role with TPN: you cannot simply turn it off. That high continuous glucose load means your patient has really high circulating insulin levels. If you abruptly stop the TPN, you risk catastrophic rebound hypoglycemia. The strict physiological rule for tapering is to have the rate for 1 hour, have it again the next hour, and then you can discontinue. And generally, you make this transition when the patient's oral intake consistently meets about 60% of their daily caloric needs. Now, TPN is absolutely life-saving for sure, but it comes with major complications. First is glycemic control. The landmark NICE sugar trial proved that overly strict glucose control, keeping it under 110 milligrams per deciliter, actually increases mortality. Who would have thought, right? So your target is under 180. Secondly, long-term TPN totally bypasses the gut. That means no cholecystokinin is released. This lack of enteral stimulation stops the gallbladder from contracting, leading to severe cholestasis and eventually biliary cirrhosis that could actually require a liver transplant. So all of this brings us to one final provocative thought. Does perioperative nutritional support always benefit the surgical patient? Interestingly, the data says no. Most well-nourished elective surgical patients actually have the fuel reserves to comfortably tolerate up to 7 days of partial starvation. So the true test of a vigilant clinician isn't feeding everyone. It's properly identifying those who are truly malnourished, the specific patients whose immune function and wound healing will catastrophically fail without your intervention. And that's what you should take away from this explainer.